right, so welcome to Grand Rounds. I want to welcome you to a beautiful day outside. I walked in by the little VA garden, and the irises that are yellow and white are blooming. I'm going to ask Alan Bridges if I can take a little cutting of those, but I better ask him before I'm actually arrested for that. So we are getting toward the end of one of our other series. So, you know, we just finished the Dream Speaker series, and we also have our Chief Resident series. And today, we're very honored to have one of our chief residents, Dr. Samantha Murray-Bainer, presenting. And before I tell you a little bit more about her and the title of her talk, I want to tell her that one of the things she did, which is really a tough thing, is she's been the person in charge of Grand Rounds. That is, and you know, like Dr. Trowbridge, somebody wants to cancel at the last minute. What do I do? And this person won't answer their email, and then she also, you know, has to go through if we have some conflicts of interest and go through presentations. And she has done an absolutely outstanding job this year. And I'd love to thank you for that. So Dr. Samantha Murray-Bainer is going to be presenting Grand Rounds today on patient satisfaction, more than just GomerBlog Fodder. Probably our best title as well. So Dr. Murray-Bainer, just a little bit about her. She did her medical degree at the University of Iowa, Carver College of Medicine in Iowa City, Iowa. She came here to spend time with us doing her internal medicine residency. She holds the Vogelman Carnes Family Endowed Categorical Chief Resident Endowment, and she has spent this last year as one of our chiefs. When I was looking through her resume, I think it's very clear she's very heavily involved in medical education, and she was in our TEACH pathway when she was a resident here, and her area of interest was multidisciplinary teams, and that's been very fruitful for her. And in fact, she presented at the Alliance for Academic Internal Medicine this past spring in 2019, and her title was Take Time to Listen, an interprofessional collaboration exercise in the sub-internship at 2 institutions, and the other institution is the other UW. So fantastic work there. She has been a preceptor for the Medicine Inpatient Acting Internship Conferences. She's also been an acute care preceptor for Phase 2 students, and we are extremely lucky and honored to have her staying on as faculty here. She's going to be a hospitalist. So with that, Dr. Murray-Bainer, come on up.
You guys hear me? All right. Thank you, Dr. Trowbridge, for that lovely introduction. I have no financial disclosures, and if I did, I'd have to review my own Grand Rounds. So I'm going to start by addressing the elephant in the room. When we talk about patient satisfaction, some of you may feel like this. It's okay. It's not your fault. You've been conditioned to feel this way by GomerBlog articles like this. And this. And these. All right, patient satisfaction surveys. They're not perfect. We know that there's gender and ethnicity biases in how patients fill them out. The way that they're distributed isn't perfect. But they're all we have currently to understand the patient experience. Why should you care? The cynical answer is money. Patient satisfaction scores are tied to value-based purchasing, and they directly impact every hospital's bottom line. They're also becoming a part of physician reimbursement as well. So while you may not be directly impacted by patient satisfaction surveys at this time, some point in the future you might be. The more important reason is that patient satisfaction surveys find out how patients feel about our communication skills, whether we care about them, how well we work together as a team, and many other factors that are vitally important to our patients. Some of you might have also heard a myth that patient satisfaction surveys are driven by things that are outside of our control or relatively trivial, like the hospital food or the art on the walls. But here at UW, these are our primary drivers. whether staff worked together to take care of the patients, whether doctors and nurses treated them with courtesy and respect, whether patient and family preferences were considered, and how fast the call button was answered. My objectives are that when you leave my presentation today, you'll have an understanding of the history of how patient satisfaction surveys were developed and implemented. We're going to review a lot of data today. I was interested to see how patient satisfaction surveys may or may not relate to quality of institution, how patients do in terms of outcomes, how we feel in reference to patient satisfaction. Are we more satisfied if our patients are more satisfied? And I wanted to understand more about how it affects the financial outlooks of our institutions. We'll end by talking about what we have here at UW, which is our Patient and Family Experience Group. We'll go through some of our current metrics, and then we'll talk about some of our ongoing projects for improvement. Let's jump right in. In the late 1970s, Dr. Irwin Press, who was a medical anthropologist at Notre Dame, posed a question to his students. He wanted them to think about whether the experience of patients throughout society and time has anything to do with the experience of the modern patient. Does a patient in our fast-paced institutions with tons of technology, does that patient have any experience at all that's similar to someone who had a home visit in 1900? It subsequently became his intense passion to study the experience of the modern patient. And in the mid-1980s, he partnered with Dr. Rod Gainey, who was an expert in statistics and survey methodology, to develop the Press-Gainey survey, which at the time was considered scientifically rigorous and validated. They then went further and formed the Press-Gainey Associates, which is an organization that provides a private vendor Press-Gainey survey, data, and analysis to over 26,000 healthcare organizations across the United States, including UW. Now, to everyone's favorite survey, HCAHPS, which stands for Hospital Consumer Assessment of Healthcare Providers and Systems Survey. So HCAHPS came about at a time when hospitals were using surveys from private vendors, meaning that you couldn't compare survey scores from one institution to another, and they were not publicly viewable. So when HCAHPS was developed, there was many goals to develop the HCAHPS. They wanted an objective and meaningful comparison for hospitals. They felt that if we were forcing hospitals to publicly report scores, it would create incentives for improvement, and increased transparency creates more accountability. HCAHPS was not designed to be used to compare individual hospital units to each other or individual providers to each other. In 2002, the Center for Medicare and Medicaid Services partnered with the Agency for Healthcare Research and Quality to develop the HCAHPS survey. And in 2003, it underwent a 3-state pilot in New York, Maryland, and Arizona, which involved over 50,000 inpatients at 132 hospitals. In 2006, it was rolled out nationally, and in 2008, the results from the HCAHPS surveys were first viewable on the Hospital Compare website. HCAHPS today is administered to patients that discharge from medical, surgical, and maternity care wards anytime between 48 hours and 6 weeks after they leave the hospital. It's decided based on discharge unit, so as you can imagine, somewhere like TLC doesn't have very many HCAHPS surveys. And the patients are selected randomly. Sometimes hospitals will also send another survey with the HCAHPS survey, like the Press-Gainey survey, to get more information. And that's what our hospital currently does. If hospitals get payment from Medicare via the value-based purchasing system, they have to have at least 300 surveys completed a year. We have way more than that. The questions continue to be updated. And one interesting example is that there used to be a question on HCAHPS about how well your pain was treated when you were in the hospital. In our changing thinking about pain, this has been updated to a question about how well providers communicated with you about your pain, which I think is an excellent change. In October 2019, HCAHPS will have 22 questions, followed by multiple demographic questions. There's only 3 about physicians. They are not questions about how well we consult our infectious disease and gastroenterology colleagues, or how well we performed that paracentesis. Rather, they are questions about how well we communicate. During this hospital stay, how often did doctors treat you with courtesy and respect? During this hospital stay, how often did doctors listen carefully to you? And during this hospital stay, how often did doctors explain things in a way that you would understand? All right. Now that we've gone through how HCAHPS surveys and Press Ganey surveys came to be, we'll now move on to a big, deep dive into the literature that I was able to find as relating to patient satisfaction surveys. There's a few caveats. A lot of these surveys are very large, studies are very large, hospital-level data, and not many of them get down to the patient level. So what we'll talk about today is mostly correlation, but I think there's still some information that can be gleaned. The first question that I want you to think about is, as healthcare providers, physicians, APPs, nursing staff, do we provide care or service or both? What do I mean by that? My last job before residency was hosting at Olive Garden. That's right, I know how the breadsticks are made. I learned some customer service skills at Olive Garden. Customers liked it when I made good eye contact, smiled, communicated well about their wait time, and made dorky small talk while walking them back to their table. I've learned a few things in medical school and residency too, mainly about the technical aspects of being a doctor. I can now work up and diagnose many medical disorders, place orders and document efficiently, perform a few procedures, and even rarely correctly identify a JVP. So, when patients are filling out these satisfaction surveys, are they only able to comment on the service that they received? Or are they able to understand some of the technical aspects of the care? This first study, which was published in New England Journal in 2008, sought to explore this question. And what they did was they compared data from HCAHPS to data from the HQA. So this is quality metrics compared to patient satisfaction scores. And they had 2,400 hospitals between 2006 and 2007 that submitted information in both of these realms. There was also 1,500 hospitals that only submitted quality metrics and not the satisfaction scores. You might think that organizations that are more likely to submit satisfaction scores are going to be fancy, small, private institutions with a "we cater to your every need" sort of attitude. These authors wondered about that, so they compared these two cohorts to each other. And what they found was that the hospitals that were more likely to submit patient satisfaction scores were large, for-profit and not-for-profit institutions. They had ICUs, many had medical schools and residencies. They also had similar Medicaid and Medicare patients and nursing-to-patient ratios. So what they did was they were looking at 4 conditions for which they had quality metrics on: MI, CHF, pneumonia, and surgery complications, prevention of these complications, and they calculated an adjusted mean score for these. They then compared these to the institutional scores for HCAHPS. And what they found was that as the quality metrics improved, so did the patient satisfaction scores. As you can see, the individual differences between these quartiles of satisfaction scores are small. But if you multiply this by the thousands of patients that were admitted and discharged with these conditions, you can imagine the significance. These findings were echoed in this study, which was published in 2015, which was very similar. It was a cross-sectional study where they had patient satisfaction scores from the Hospital Compare website, and this time their quality metrics came from the AHA, and they had them for MI, CHF, and pneumonia. They looked at 2 specific questions from the satisfaction scores. Would patients recommend the hospital, and did they rate it in the top box, meaning 9 to 10 out of 10? What they found when they compared these 2 buckets of metrics was that there was a small but significant correlation between improved satisfaction scores and improved adjusted mean scores for the quality care for these conditions. Now, they were worried that maybe a hospital that's good at quality care for MI is good at everything. And they didn't want to overinterpret their data. So what they did was they compared the quality metrics to each other. They thought that if, they did really well in MI and they did really well in CHF, maybe they're just good at everything. And what they found was that there was only a moderate correlation between the quality metrics to each other. And therefore, they felt that they could believe this data that they found. There was a small but significant correlation between quality and satisfaction. So, can patients identify quality care? On an individual level, probably not. One patient may not be able to say, this provider gave me better technical care than this provider. But when they are surveyed in mass, they demonstrate that they have some understanding of the quality of the care that they received. We'll now move on to, are satisfied patients healthier? In the medical literature, the majority of this is focusing on mortality and 30-day readmission rates. We'll start with the 30-day. So this article, which came out in 2011, looked at 1,800 hospitals for which we had readmission rate data, clinical performance measures for MI, CHF, and pneumonia from the AHA, and patient perception data from Hospital Compare. And what they found was that there was a lower 30-day readmission rate associated with overall satisfaction, so patients rated the institutions higher, and a better satisfaction with the discharge process. This next article, which came out in 2017, focused on one specific question from the satisfaction survey. Would you recommend this hospital to others? And they compared that to the 30-day readmission rates for this hospital. And what they found, again, was as better satisfaction scores went up, so did the 30-day readmission rates. They went down. Now, this article, which came out in the Journal of Hospital Medicine in 2018, was interesting because it got down to the patient level. They wanted to see whether they could predict whether someone is going to be readmitted based on their patient satisfaction scores. A lower satisfaction score, maybe they're more likely to be readmitted. A better satisfaction score, maybe they'll stay out of the hospital. What they found was that the rates of readmission between better and lower satisfaction scores were the same. So they didn't feel that they could make an association between those. Now to mortality. This article, which came out in 2003, was looking at 29 hospitals in Ohio. These hospitals were somewhat similar to our own. Many were urban. A third had medical schools and residencies. And they were looking at patient satisfaction scores and associating them with severity-adjusted hospital mortality at these institutions over 4 years. And what they found was that the patient satisfaction scores predated HCAHPS because this was so long ago. So these were from private vendors. And they looked at mortality for 6 conditions: CHF, MI, GI hemorrhage, obstructive airway disease, pneumonia, and stroke. And what they found was that as mortality improved, so did satisfaction. And they also found that as satisfaction improved for some factors, satisfaction with coordinated care and the discharge process, so did the mortality. That was statistically significant. They did find a positive correlation between satisfaction with physician and nursing care, but it was not statistically significant. Now, this next article, which came out in 2012, was focused on different data. They had 50,000 respondents to the medical expenditure panel survey between 2000 and 2007, and they compared that data to HCAHPS scores for these institutions. They were looking at utilization, expenditures, and outcomes. And what they found was that as patient satisfaction scores improved, mortality went up as well. The most satisfied patients had a higher mortality with a hazard ratio of 1.27. What I will say to that is, through my reading, I have noticed some articles commenting that patients in their last year of life tend to be more satisfied. Maybe this reflects an increased contact with the healthcare world. This last article, which came out in 2009 in Circulation Cardiovascular Quality Outcomes, was very interesting because they were able to get down to patient-specific data. They had 3,500 patients for which they had patient satisfaction scores from the Press-Ganey surveys and Crusade Initiative data, which was the quality metrics. So they had MI guideline adherence scores and mortality information. What they found was that satisfaction went up and was correlated with 13 out of 14 of these MI performance measures. They also found a positive association between mortality and these patient satisfaction scores as well. So, when we ask, are satisfied patients healthier? The data is a bit mixed here, and the majority of it is hospital level, and therefore a little hard for us to interpret. This has been explored extensively in the surgical literature. There's a lot of different studies that look at satisfaction scores as relating to one particular procedure or another. And I think we need more data in the medical literature to show us, as providers, that our patients are doing better if they're more satisfied. I think that will get more buy-in. We'll now move on from how the patients are doing. How are we doing? This comes at an interesting time following last week's Grand Rounds, when we learned that patients who see burnt-out ambulatory physicians are more likely to be satisfied. I didn't specifically look at burnout. I looked at provider and employee satisfaction as relates to patient satisfaction. Press-Ganey looked into this. In 2005, they took data from 111 hospitals for which they had inpatient satisfaction scores and employee satisfaction scores with the overall institution, and they compared them. And this is what they found. A very positive association. Now, this came straight from Irwin Press's book, and it's not public, so I wasn't able to find any additional information about this graph. They went further, and they looked at provider-specific satisfaction. So they looked at physician scores compared to patient satisfaction scores at 94 institutions this time, also in 2005. And again, a fabulously positive correlation. Press-Ganey is trying to sell its services to healthcare organizations. So it would behoove them to show that patient satisfaction scores go up, so do provider scores. I was a little anxious about this, so I wanted to see if I could find any other data from a different source. And thankfully, someone explored this at the VA as well. So this time, these authors took data from the all-employee survey, which all employees fill out at VA hospitals, and they compared this with HCAHPS scores for these institutions and the VA survey of healthcare expenditures of patients. When they looked at employee satisfaction with the overall organization and compared this to the HCAHPS question of would you rate it in the top box, they found a statistically significant positive correlation. Now, this graph is not as impressive as the Press-Ganey surveys, but it's still reassuring. They did not look specifically at physician satisfaction, but they did look at whether someone is satisfied with their job specifically. And when they compared job-specific satisfaction to patient satisfaction, they found a positive relationship, but this one was not statistically significant. So, are we more satisfied as employees and healthcare providers when our patients are more satisfied? Again, the data's a little mixed here as well. I would think that if we as a healthcare team show that we value each other and make each other's lives easier, make each other's jobs more efficient, that maybe patients can perceive this and would rate us higher. I certainly think that patients can perceive when their providers are burnt out. If they don't show as much empathy, if they're not taking as much time with them as they need. So what I want us to do is if we ever explore projects targeting improved patient satisfaction, we need to be careful not to make our employees or our healthcare providers' jobs harder or less satisfying. We'll now move on to an exploration of how patient satisfaction scores impact the bottom line. So in 2013, Medicare began withholding 1% to 2% of hospital reimbursement based on value-based purchasing and quality metrics, and this was determined by best practices from the CMS and HCAHPS scores. This article, which came out in 2013, first explained this to me, and then gave a very interesting anecdote of how this could impact an organization. So this hospital is an urban hospital in New York, has 500 beds, an ICU, it's a teaching hospital. It's similar to ours, however, it has a different payer source. 50% are Medicare, 35% are Medicaid. And they saw a dip in their satisfaction scores. And they plotted out what would happen over the course of 5 years and how much money they would lose, which would be $5 million over the course of 5 years. Now imagine the flip side. This shows how negatively value-based purchasing can impact an institution. But if you're doing well in your satisfaction scores, you're going to get these doled out to your institution through value-based purchasing. I wanted to move beyond how HCAHPS directly impairs financial outlooks and look more into the global question of, are satisfied patients bringing our organizations more money? So if you think about this as a big business model, I'm an Amazon Prime customer. I enjoy my experience on Amazon Prime. I'll probably continue to order things on Amazon Prime. If I enjoy the experience of flying with Delta more than Frontier, I probably will still buy Delta flights even though they're more expensive. And Hospital Compare is kind of an ugly version of Yelp. We can judge businesses based on ratings. So these authors sought to see whether these big business concepts relate to healthcare. They wanted to know whether a positive patient experience is associated with profitability for hospitals through return to provider behavior and referrals. So they looked at 3,700 hospitals for which they had net patient revenue, net income, and operating margin data. And they compared this to their overall HCAHPS scores. Their first hypothesis was that a positive patient experience would be associated with increased net income. And indeed it was. For every 1% of patients that are going to recommend this hospital, the hospitals would make $247,000 more dollars. So this beta number is the coefficient in thousands of dollars, plus or minus the standard error. For every 1% of patients who would rate the hospital in the top box, again, 9 to 10 out of 10, the hospitals would make $288,000 more dollars. What was even more impressive is how negative ratings can lose the hospital's money. For every percentage of patients who would not recommend the hospital, it would lose $741,000. And for patients who would rate it in kind of a middling level, 6 or less out of 10, the hospital would lose $550,000. They performed this analysis with the net patient revenue and the operating margin as well, but the data really reflects what was shown here in this graph, so I'm not going to go through it. These quotes are very cynical, but very poignant. We live in a world where we have ratings for all sorts of businesses at our fingertips 24 hours a day. Patients are increasingly demonstrating that they are able to affect how our organizations are doing. My husband and I were talking with our neighbor the other day, and I told her that I was going to give this big presentation on patient satisfaction. And she made a comment that from a patient perspective, things are changing. If she doesn't like her doctor, she doesn't agree with what they're saying, she can get a new one. So, do satisfied patients make hospitals more money? Resoundingly, yes. Through value-based purchasing, through increased return to provider behavior, and through increased referrals. All right, we'll now move on into an exploration of what we have here at UW. We'll start by introducing you to the Patient and Family Experience Group. We'll go through our own metrics, and then we'll end by talking about some of the ongoing projects we have for improvement. When you look at the Patient and Family Experience Group on the UW Health website, you see this. We have made a promise to our patients. We promise to listen with compassion, communicate effectively, and respect you. I had the opportunity to meet with the Director of Patient and Family Experience, Linda Sparks, a few months ago, and she taught me about how this came to be. The organization was formally founded in January of 2018, and it absorbed some aspects of UW Health that already existed. First and foremost, patient relations, which is the group that receives concerns and complaints from our patients and then deals with them. The second is the hospital volunteers, of which we have over 900 spread across the healthcare organization. Then we have the subgroup, also called patient and family experience. These are the folks that manage our HCAHPS and Press Ganey surveys, analyze the data, come up with improvement projects, and also run with our patient and family advisors. Who are they, you might ask? Patient and family advisors are former UW Health patients or family members who have decided to give their time to make the experience of current patients better. There's over 200 of them currently. They're involved in 11 different councils across our organization, anywhere from AFCH to oncology, behavioral health, and transplant. They're involved in many different projects across our institution, anywhere from UW Health website redesign to suicide prevention groups. They're also involved in our residency program in a really cool way through the Communication Advisor Program. So in late fall of 2018, we introduced the Communication Advisors to our senior residents on GMed. So the Communication Advisors are a subset of these patient and family advisors who have been trained to observe healthcare providers on their communication skills. So what they do is they join one of our senior residents when they're on their inpatient GMed rotation, when that senior is alone. They don't have their intern with them, and they're rounding on patients by themselves. The communication advisor goes in ahead of the resident, consents the patient, and then observes the interaction between the resident and the patient. They then stay behind, get feedback from the patient on how they felt about that interaction, and then they provide this feedback to our senior residents in the form of written communication. So far, the seniors have seemed to respond well to this and seem to welcome this feedback. Jenna Wright, who is involved in this program, was willing to share with me some of the statistics and how patients are rating our senior residents so far. As you can see, patients think that we're excellent at greeting the patient and family in a way that made them feel comfortable. 80% felt that residents are excellent in talking without jargon. 80% rated them as excellent in showing care and concern. But there was areas where it seemed that we could have some improvement, namely whether we understood the patient and family's main health concerns, whether we gave them as much information as they need, and whether we spent as much time with them as they felt that they needed. Does this reflect that we need to help our residents set expectations for these patients so that they can meet these? Or does this reflect that our residents have a bit more time crunch on them than they used to? There's a lot more rounding that we do now, and there's a lot more curricular activities. These quotes are really neat about our residents, so I thought I would share them with you as well. The resident was talking about injections with the patient and asked, "What's your understanding of why we want to do this?" They demonstrated empathy. "Sounds pretty uncomfortable. I can see if there's anything else I can do." Not a great feeling, I know. The doctor showed care and concern for patients. A patient was telling her that he knew he wasn't going to get a liver transplant. And she asked, "How do you feel about that?" We'll now move on to look at our own patient satisfaction scores at UW. We'll start by going to the Hospital Compare website, and then we'll move internally to the data that we have on UConnect. When patients Google Hospital Compare, this is what they get taken to. They're able to look at one location and compare up to 3 healthcare organizations for that location. So for our example, I used UW Hospital and our 2 Madison sister hospitals, Unity Point Meriter and St. Mary's. I included this slide so that you can see all the different things that patients are able to get information on. So they can get patient experience data, they can get information on quality of care, and they can even get payment data. The first thing that we'll look at is a question about doctor communication. So if you remember, there was 3 questions on HCAHPS about physicians, and what the Hospital Compare website does is kind of collate them into one big category of whether physicians always communicated well. And when you look at these 3 organizations compared to Wisconsin and nationally, you can see that we're all doing about the same. Now, when we look to see whether patients would rate the hospital in the top box, 9 to 10 out of 10, you can see UW starts to stand out a little bit among our immediate peers, among Wisconsin hospitals, and especially compared to the national average. So, yay us! All right. Hospital Compare has so much data, I'm going to move on to what we have in the house. So if you go to Quick Links on UConnect, you can click on this thing called ClickView UW Health. And many faculty members, and maybe some residents as well, get access to this, and it's a treasure trove of information. I looked at both inpatient and ambulatory satisfaction data and found that it was a bit of a wormhole. You can get as specific on the inpatient data as one HCAHPS question for one service or one HCAHPS question for one unit, even though HCAHPS wasn't supposed to be used to compare individual units. This is what it looks like when you first open the inpatient satisfaction scores. So you can see we have an overall rating, and then we have the 5 primary drivers of our satisfaction scores here. So I chose to show you our 2019 data, but you can look at 2018 or 2017. For each of these scores, you can see our goal, whether we're meeting that, and then you can see how many people have answered this question so far. At the bottom, it will also show a rolling 12-month top box average. And as you can see, for our overall rating, at the beginning of 2019, we're starting to see a slight dip. I then dove deeper into questions that I thought would be more interesting. I looked at one doctor question so far. How often did doctors explain things in a way that you can understand? And I thought, let's see how our residents are doing. So I looked at GMed scores, and I compared them to family medicine. And in 2018, you can see that our top box scores for this were all over the globe, from 60% to 75%. In 2019, our scores are somewhat similar, but we're seeing a little bit of a decline. Maybe by the end of 2019, this will shake out and be the same, or hopefully better. But maybe this is a warning sign that we need to work harder on talking without jargon. Another of the 3 doctor questions, how well did doctors listen carefully to you? This time, I chose to look at the cohort of my past, the medicine residents, and compare them to the cohort of my future, the hospitalists. And as you can see, these scores are all over the place for 2019. What's really interesting about this data, though, is that on GMed, at any time in a patient's stay, they might be taken care of by one of all 4 residents, A or B side. And it's fascinating that A and B sides could be so different on these satisfaction scores. We'll move on from the doctor-specific questions. Are patients recommending UW Hospital? This time I wanted to show you the 2018 data, so you can see our top box score over time throughout 2018. And it looks like at the end we saw an impressive uptick. Oh, by now you've got to be wondering, what about the food? Do they like our food? Good news, they do. All right, they like us as physicians and healthcare providers. They like our food. They actually know what they're supposed to do when they discharge from our hospital. You can find this data too. I chose to compare services on which it is very important that they know what to do when they discharge. Bone marrow transplant, medical transplant, liver transplant. And I compared these to our resident-run services, GMed, cardiology, and heme. And as you can see, these transplant services are kicking our butt. Do we need to take a leaf out of their discharge process? I would argue that a patient discharging with new AFib or a complication of their diabetes or a substance abuse issue or mental health disorder needs to know as much about what is expected of them at discharge and what they are responsible for as someone discharging with a solid organ transplant. All right, I didn't want to leave our outpatient doctors on the lurch, so I'll go into the ambulatory data as well. This looks a little different than the inpatient data. They don't use HCAHPS scores or those specific questions, but what's neat about the ambulatory data is that we can get down to the provider level of satisfaction. Don't worry, I won't go into that today. I started by looking at UW internal medicine clinics overall. So if we were looking at one specific clinic, it would show up as the blue box, and it would be compared to the red box, which is the average for UW internal medicine clinics. The 6 metrics that they look at on the ambulatory slide are likelihood of recommending the clinic, whether the staff worked together well, whether they responded to patients' concerns and complaints, whether they made an effort to include the patient in decisions, their sensitivity to the patient's needs, and the overall cleanliness of the clinic. I was an East Clinic resident provider, so I was curious to see how some of our resident clinics would do compared to the overall average. I know what East Clinic looks like, I know how the clinic model works, and I'm aware that there's been a bit of nursing turnover in the last couple years there. When you look at East Clinic, what's really amazing is that in the scores where you think nursing staff being continuous to be very important, responding to concerns and complaints and how well the staff work together, I think it's amazing that East Clinic has maintained these scores through that tough transition. I then went on to look at the bright new shiny penny clinic, Union Corners, which has a slightly different clinic model, and I was curious to see how patients would rate Union Corners. Turns out they like Union Corners. It does better in every metric compared to the average. Does this mean that we just have really awesome providers at Union Corners? Probably. Some of them are in the audience. Are patients demonstrating that they like this new clinic model? Or are they showing that they are swayed by a fancy new clinic? Who's to say? We need more data. All right. Now that you've seen where things have been, how they are now, where are we going as an organization? Linda Sparks was willing to share with me some of the ongoing projects for improvement. The first one is a consult communication pilot that has been rolled out at AFCH with the goal of improving the communication between consulting services and the primary service and the patient. This eventually will be rolled out at UW, so we'll see how it goes. ClickView is also going to make patient comments viewable. This is already viewable for the ambulatory clinics and the ER, and at some point this summer, we'll be able to see comments on our internal medicine satisfaction surveys as well. They're beefing up their ambulatory and inpatient provider coaching programs to help us all develop our communication skills. They're partnering with the patient safety and nursing improvement groups, nursing quality groups, to develop a collaborative improvement project with many goals. They want to improve RN satisfaction, they want to improve the hospital's culture of safety, and they also want to improve the patient experience. And a global issue for UW, access. Whether that's getting transferred here as an inpatient, getting into a new primary care provider, or getting into a specialty clinic. The Patient and Family Experience Group is currently involved in the specialty clinic redesign to help improve access. We've covered a lot today, but I want you to leave with the following. We are customer service providers. We may not have gone into medical school or nursing school to be this, but we work in a customer service industry. That's the way of the world now. I was reading an article last night about how customer service businesses are rated, and they lumped hospitals in. They made patients compare hospitals to a type of animal and a type of car. And animals that were chosen were like horrifying, scary animals, and the cars that were chosen were things like an old Volkswagen van, a Ford Pinto. That's how people feel about hospitals currently. We also were rated 27 out of 31 on these businesses. We were 10 points below the tobacco industry and right above the Internal Revenue Service. So at least we're doing better than the IRS. The only way that we can understand what our customers want is through patient satisfaction surveys. So if you don't like them, or if you don't like the questions they ask, then you need to get involved and help make changes to them so that we ask the right questions and get the right information. As they stand currently, at an institutional level, patient satisfaction scores do tend to correlate with organizational quality scores as well. And clearly, satisfaction scores directly impact the bottom line of our organizations. The data is a little bit more mixed when we look at whether patients do better in terms of outcomes if they are more satisfied. It certainly seemed that there was positive correlations and maybe positive trends, but I think we need more information here to get more buy-in from all of you. We also saw that maybe provider satisfaction and employee satisfaction goes up when patient satisfaction scores are improved as well, but we need more information here too. UW is doing quite well on our patient satisfaction scores overall. It ebbs and flows, and we can always continue to work on it. ClickView is a gold mine. For the learners in the audience, I highly recommend that you explore ClickView to see if you could come up with a simple project in which you can track satisfaction scores, and there's also quality metrics on there as well. And last, when you are dealing with a problem on your hospital ward or in your clinic, consider involving the patient and family experience group. They bring a very interesting perspective to the table and may help you come up with a great solution. All right, I'd like to thank some individuals. Linda Sparks, the Director of Patient and Family Experience. Sean O'Neill, who was my mentor for this project. Jenna Wright, who shared that communication advisor information with me. Dr. Vogelman, who's been my mentor for the last 4 years. Jeremy Smith, who helped coach me on this presentation. My co-chiefs, without which this year would not have been as much fun. My husband, Kyle, and my parents, Judy and Steve. Here are my references, and I'll take questions.
Thank you for an outstanding grand round. We have time for questions, and I'll ask Sam to please repeat the question from the audience.
Dr. Carnes.
Well, that was fabulous. Thank you. So I have some concerns now that patients are viewed as consumers, that unintentionally this is going to reinforce institutional racism because patients with physicians of color lower ratings and are more likely to refuse care from them. So once you tie reimbursement, this is actually a direct violation of Title 6 and 7 of the Civil Rights Act.
So Dr. Carnes' comment was that as we increasingly view our patients as consumers, it allows for some racial and ethnicity-based prejudice to come through in how the patient satisfaction scores are given. And I certainly recognize that concern, and I don't have a good answer to that. It is a little scary. Dr. Vogelman.
I really like it. Just a unique grand round. Thank you for going through those data. Do you think Medicare is spot on as having this be a driver towards reimbursement, or is it an overreach? Is the data good enough for millions of dollars to be shifted between hospitals? You mentioned one that had 50% Medicare and 35% Medicaid. They're very dependent on this money to provide care to people who have limited resources.
I would say that to Dr. Vogelman's question was whether it's valid that Medicare withholds money based on satisfaction scores. I definitely recognize that concern as well. I think that it's more reasonable to be based on quality metrics, and there are many questions on HCAHPS that are not about specific providers or nursing staff that I think could be used that get more to the organizational quality, like whether the hospital ward is quiet at night so that they get a good night's sleep. I think we have to be careful which particular parts of the HCAHPS survey that we use to tie to reimbursement. Oh, Dr. Rosenberg.
Wonderful talk, Sam. So, one concern I have with the more we tie this to, any concerns that the way we practice as providers might change in a negative way, ordering more tests, practicing less evidence-based medicine. I say that as a specialist, but it applies to everyone, I think.
I've heard Dan Rosenberg brought up a good point that there's some concern that if we are becoming more consumer-based in how we practice, maybe we're going to be ordering more tests and doing more what the patients want. I was worried about that when I went into this, and I didn't really find any articles that supported that. I'm sure that they're out there, and especially more in the ambulatory side. I think what this should tell us is that we need to work on setting correct expectations for patients in a non-judgmental way with good patient-centeredness to help them towards what we want without coming off as paternalistic. So I think this is a good motivation to improve our communication skills. but not to just order pain meds and diagnostic tests. No, Amber asked whether modern patients have anything to do with patients of yonder year, and it never was answered in his book, but that would have been very interesting. I suspect they're different.
Do you know if there are any data looking at patient characteristics or family characteristics that are tied to satisfaction rates?
Yeah. So the question was whether patient satisfaction scores are related to socioeconomic status or particular characteristics. Definitely. A few examples that I'll give is that elderly female patients are more likely to rate their providers higher than young male patients. Certain ethnicities actually rate their same ethnicity lower than Caucasian providers. So there is a lot of strange bias in this data, and I think it should trigger an exploration of these biases rather than just sweeping patient satisfaction scores under the rug. There's a question in the back, I believe.
Do you have provider-level data, and asking not to markedly be punitive, but like, do you have where you could find these super communicators and have them be more showcase what they're doing?
In the outpatient setting, so the question was, do we have provider-specific data? Ambulatory data, yes. So they are able to see which clinic providers are better in their satisfaction skills, and this has led to targeted coaching. So I could see it being used with a goal of helping that provider improve their communication style rather than punitive. I would hope that we wouldn't be using them to directly be punitive. We haven't seen that in inpatient setting because they are based on discharge unit, not discharge provider.
I think one of the difficult things I think in the outpatient setting compared to the inpatient setting is I think often in the inpatient setting, patient preferences and our goals for the patient need to be aligned. If someone has a heart failure exacerbation, oftentimes what we want to do for them will also make them feel better. But in the outpatient setting, oftentimes we're engaged in preventive care, which are our goals might not align with patient preference. And it seems like some of the only data that was presented on outpatient.
Yeah, I mainly did focus on inpatient.
In that EC data, which showed higher rates of hospital admission and higher rates of mortality for more satisfied. Do you have any other data to speak to that?
I didn't. The question was more about how in the ambulatory setting, a patient's preference may not align with the provider preference, and on the inpatient setting, those are a little bit more aligned. And I will say that I went into this with a bias of being a future inpatient provider. So the articles that grabbed me were the ones that were inpatient. So I'm sure that data exists somewhere, but I didn't find it. Yeah. Yeah, that's an excellent point. So the comment was that TAC is rated higher than UW Health, which is true. And they have the same providers at TAC that we do at UW Health. And I think that and the Union Corners data reflects that the way that these questions are structured needs to be edited in a way that's a little bit more objective. But that's really hard when we have millions of patients. We can't teach them all how to be good survey takers. So we need to figure out ways of asking the right questions to get at what we actually want to know.
So I'm struck by the first bullet. We are customer service providers. And it makes me wonder two things. As a profession, we have always valued communication and empathy. We even look to our forebears in our profession around that. And I'm wondering a little bit about when it changed. How did we get to where we are? And I'm not
excellent points. So Dr. Chittum mentioned that, I forgot the first half of your thought.
Just when did it change?
Yeah, when did it change? January of 1989. No, just kidding. I have no idea. I would say that probably around the same time that HCAHPS began to become developed and hospital compare websites rolled out. At the same time, all of our phones, we got Yelp and started judging every single thing possible. I want to be careful to say that I don't necessarily support the fact that this is where we are at. I just wanted to present it as this is the way it is currently. And I think we just need to educate our learners that this is the current healthcare environment. It may not be the right thing. And I think as we go throughout time, hopefully our patients will start to, I think the problem is that healthcare is so mystifying. It's behind a curtain. And until we demystify it, patients won't know what to expect and can only rate it based on their own experiences. Yes, Dr. Brunner.
So, I guess one question I had was regarding the timing of when patients fill out the HCAHPS surveys. So, there's some evidence that people remember experiences based on sort of the peak of that experience, and also the evidence of sort of bias. So, if you had the survey right at the end of the hospital stay versus 4 weeks after versus doing the surveys during the hospital stay, you might get different data.
Yeah.
When is normally administered?
So the question was, when do these surveys get distributed? Because we know that there's probably some term for this bias, but recollection bias or something impacts how we fill them out. And so they're administered between 48 hours up to 6 weeks after somebody discharges. There are some hospitals that will do it via telephone too. And what they found is that people filling out the survey on the telephone rate higher than people filling it out on paper. Because you don't want to be mean to the person on the other end of the line. So again, these are not perfectly structured surveys.
Thank you again for a wonderful presentation.